Good evening, ladies and gentlemen. Good evening. If I need this. You can still hear me, right? Yes. All right. My name is Mary Ricketson, and it's my pleasure to welcome you tonight to our salon for our conversation on one of the most important issues of our time. We are honored today to have an absolutely stellar panel. I don't think you could find more informed people to speak on this subject anyplace. And we're very honored to have you here, too. If you haven't been in the Women's College before, please come back and see us. We love to have folks like you come visit us. Now, we had a reception earlier, and the question I heard buzzing around is, what's a salon? I'll cut right to the chase. No free haircuts tonight. Okay? That's not the idea. A salon was a convention of the 17th and 18th century. It's a gathering, and it was held partly to amuse, but mostly to increase the knowledge of all the participants by conversation. The key thing is, it had to be under the roof of an inspiring host. And boy, can we deliver with our own Dean Lynn Yanko.
Mary did not tell you that she is a university professor here at DU and also Dean Emerita of our law school. So she is quite humble in her introduction, but we are delighted to have Mary here as one of our faculty members at the Women's College. So Mary, thank you for introducing the salon, our inaugural salon. And thank you all so much for being here tonight. We are thrilled at the University of Denver that we are hosting the first presidential debate. It is astonishing, really. And many of you have heard Colorado referred to as a purple state because we've got enough red and enough blue for interesting conversation. And so I do believe that the folks who choose locations chose wisely when they chose the University of Denver. And as a debate host, all of the academic units at the university were thinking, what could we do to elevate conversations on the great issues of the day? And so why tonight, why this panel, and why the Women's College? The White House Project is a national organization called such because they would love to see a woman in the White House. But in addition to that, the White House Project looks at any number of sectors and asks the question, are there women in positional leadership roles? We are fortunate at the Women's College to be updating that national report called Benchmarking Women's Leadership. Currently, the data shows that, on average, only 18% of corporations, of colleges and universities, of law firms, of the military, of the people you see on the editorial pages or on Sunday morning news, only 18% of those are women. According to the data, the American public is actually ready to have women in those positional leadership roles. However, we still don't see those numbers increasing to any great extent. So as we contemplated how this college would talk about the great issues of the day, what we wanted to do was to invite men and women into conversation about those issues. And unlike the Sunday morning news, what we have before you are 5 extraordinary thought leaders who happen to be women. And so all of our salons will feature thought leaders who are women who will talk about the issues of the day. And as I conversed with each one of them, the conversation went as follows. If you would choose to talk about this from your perspective as a woman, or to talk about women and healthcare policy, that is certainly your prerogative. But I know all of you, and you have other perspectives that are broader. And so our conversation may move to gender, it may not. But this particular issue, healthcare policy, is one that impacts all of us. I would dare say that there are no longer strictly women's issues. I think all of the issues before us in this day and age, quite frankly, impact all of us, women, men, white women, black women, mixed race. I mean, we have to be in this conversation in a way that celebrates both who we are as a nation and the diversity of this nation. This college is dedicated to creating opportunities for all women to achieve an undergraduate education. And so our goal also in our salons is to show you both diversity of thought and diversity compositionally. And we invite you to consider how different populations may look at this issue from different lenses. It's an important conversation to have. So let me introduce and then move on with the conversation. You have before you at your seats the bios of all of the participants. I don't know about you, but I'm certain that all of you are highly educated people who can read a set of bios. So let me simply introduce our panelists tonight. And I've said to them, what I expect is a conversation between them. This will not be something that I will ask a question and then each one of them will answer in course and then we'll move to the next question. We will have a conversation on healthcare policy. We will talk for a bit and we will certainly then open it up for questions from our audience. So let me begin by introducing to my immediate right, Dr. Jandel Allen Davis, who's Vice President at Kaiser Permanente. Annie Warhover, who is President and CEO of Colorado Health Foundation. To her immediate right, Toti Kadavid, who is co-founder of Excelente Marketing and Public Relations and a board member at Colorado Health Foundation. To the far end there, not so far away that we can't have a conversation, I hope, Joan Henneberry, who's Principal Health Management Associates and a former cabinet member in Governor Ritter's administration, and Chris Woolsey, who's the Senior Vice President and Chief Communications Officer of SCL Health System, which includes Exempla. I want to make sure I got that right. Thank you. So what I'd like to do is to open up with a question, not surprisingly, about the Affordable Care Act. And so let's just start, and I'm happy to have a brave panelist begin. I'm not going to identify someone to start. But I would really like us to first talk about the Affordable Care Act and how you see it affects health care for Coloradans. Chris, are you looking?
I'll be brave.
Right on.
Well, I think, the major point is it's up in the air now in terms of what will survive ultimately from the act as the Supreme Court looks at it and looks at its component parts, whether the mandate will survive, and then whatever happens on the federal level, what will the states then decide to do if it doesn't pass, all or in part. I think from our perspective as a hospital system, we've realized that regardless of the law's passage or not being passed, we're going to continue down the route of trying to provide as much access to health care as we can, focus on quality, focus on affordability, all the kinds of things that the law sort of laid out that are happening in the market anyway, bundled payments, these kinds of risk arrangements with physicians. Those things are happening regardless of what happens at the federal level. So we've really taken the position that regardless of the act, we have to move forward on doing those types of things anyway.
What I'd add to it is that, in a sense, the Affordable Care Act, it was actually characterized this way right after the bill was passed, which is it's the end of the beginning of health care reform. And that's the best way to think about it. It was, regardless of what happens, therefore, in June or let alone in November with the election, the fact is that health care reform was a game changer, and it was a necessary game changer because there was a ton of swirling, but not necessarily the community will, let alone the political will, to actually move the conversation. So, in a sense, change has already happened. I mean, we're all parts of complex adaptive systems. You perturb them and they do things. Mm-hmm. And some of that reorganization will be good, but not all of it will, because the one thing that folks hate more than anything else is change. And so there will still be a need for communities and many of the folks here on this panel that I so respect to continue to push some really, really important agendas to deal with both coverage, that is access, but more importantly, quality, mm-hmm. and finally, affordability.
I would add that, one of the things that doesn't ever come out about, the Affordable Care Act is thousands, hundreds of pages. And we talk about it in terms of insurance primarily, that it's going to provide coverage for a lot more people than are covered today. And we know that if you have health insurance, you're more likely to have a regular source of care. And that's a really good thing. So health coverage, I think, is a very important aspect of it. But there are other aspects of the Affordable Care Act that I think have been kind of suppressed as a result of the attention around the Supreme Court decision. And one is, bringing it home to Colorado, is there's money for prevention. So one of the grants that Colorado has already received as a result of the ACA is a $3.7 million grant for home visitation programs. We know, and the evidence shows, that home visitation programs work in terms of taking care of moms and babies after they're born. In fact, we can even bring home the economic impact of that. For every dollar spent at the Nurse-Family Partnership, we're saving $5. I mean, that's a pretty good return on your investment. So Colorado has already received almost $4 million for home visitation programs, a program that is evidence-based, that we know works, that helps moms bring up healthy children. That's a real, those kinds of things don't make the press, but I think it's important that we acknowledge that the Act includes more than just coverage.
Mm-hmm. And I'd like to add that for women in general, it brings hope. Hope in the sense that, I don't know how many people in the audience, but every one of us knows somebody with a special needs child. I happen to have an amazing one. And it's so hard to get insurance. It's hard to, and for many people, it wasn't my case, but I have known many people in the same situation who cannot move from job to job because then they will lose the insurance, and then no other insurance will be able to receive, this whole package that we bring with this type of little ones. So that is hope. And as a business person, I also think that the word is also hope and savings. Right now, I know for a fact that there's a lot of small businesses who cannot afford to provide insurance to their employees. In the past, we used to do 85%. Now we're doing 50% because costs keep growing up. Mm-hmm. And then we need to cut somewhere. So if at least, we do 50 and we do much better than a lot of small businesses. But what this is going to bring is affordability. And that is a huge, when we're talking about surviving as a small business, that is a huge component.
I think it's pretty indefensible to say that we were all happy with what life was like prior to March of 2010. And you have to give Congress, frankly, they debated the bill, they crafted the bill, they passed the bill, and whether there's not a person in the country who thinks it's perfect. You cannot possibly debate and create something of this magnitude. This is huge social and economic change legislation. And believe me, this is economic change legislation as much as it is social. So they're not going to get it right the first time. And we should not even have that expectation. What we should have an expectation, I believe, of our policymakers and the people we elect is that they will continue to engage in thoughtful dialogue and use data and research and science whenever it's available to them to make improvements along the way and to continue to make sure that it gets better and better and better. Now, I'm a little skeptical that they're going to get there because of the culture that exists right now in Washington, but that's what I think we would all hope for, both as consumers of the healthcare system, as payers and contributors toward the cost of those efforts, and as voters, that we want them to continue this conversation and to recognize it's not perfect, and we want it to continue to evolve and get better.
Other comments? So let's talk about the impact on Colorado, given that the Affordable Care Act right now, the fate is a bit uncertain. So what are we prepared to do as a state if all or part of this act is struck down or repealed?
Well, I'll begin by saying Colorado actually began sowing seeds for massive, I would say, transformational change in how we deliver care years before the Affordable Care Act even came to be, whether we're talking about Governor Ritter's building blocks for health care reform, which have a number of the components that actually are in ACA in one way or the other, or the 208 Commission, which actually started a lot of the work, and we've got one of our commissioners sitting there in the audience, and Donna Marshall. Whether it was that work, whether it's CIVIC, the creation of the Center for Improving Value in Healthcare, which has a very ambitious agenda, and we'll see where things go over time. Colorado actually is is leading the nation. I mean, there's lots of eyes on Colorado. Even the creation of our health benefit exchange, there are people wanting to see what we do to serve as a model for those states that have chosen to do it. So that darn horse has left something, the barn or the train left the station or something. I think we're on our way, and it's what's so wonderful, frankly, about living here is we can roll up our sleeves and get some stuff done. Right?
Well, I would second that, and even prior to Colorado, there are what I call pioneer states. If you look at Washington and Oregon and Vermont and Minnesota and Tennessee, I mean, states from both sides of the aisle, both led by different governors, different parties over time, and they started realizing in the mid-'80s that the trend was not looking so good, and that they needed to really begin to address coverage and public health and prevention and payment reforms. And so I think that's part of the reason why we came to the conclusion as a society that we needed some federal overlay. Is it really wise to do this state by state by state, 50 states at a time? And why should you have to be more poor in Colorado than you are in Minnesota in order to get subsidized health insurance? Does that really make sense for us anymore? So I think that it was really some of the experimentation that had gone on at the state level for 20 or so years that we finally came to the conclusion it's time for some national solutions.
I'd echo Jan Dell in terms of Colorado being ahead of things in the electronic medical record arena. That's another place where we, I think, have stepped ahead leaps and bounds in terms of getting information shared between different providers in electronic medical records so that you really can have a holistic view of coordinated care for patients, and that's going to be so critical. And it is expensive to do, but once you do have that kind of access to data in a real-time way, it can make a very real difference in folks' care. And then the other example here in our state is over in Grand Junction and the Mesa County model that has been recognized nationally, and in fact Obama even visited the community. And while it has unique characteristics in that that community happened to come together in a cooperative manner that doesn't always exist in other communities, where the providers were aligned, the health plans were aligned, the employers were aligned, and they all said, you know what, we want to do the right thing, provide affordable access to quality care. How can we do it together? That kind of cohesive market doesn't exist everywhere, but it has become a model for the nation, and it has been called out as a model. So I think there are lessons there we can try to duplicate, even though politically and the cooperation level in different markets isn't exactly the same. There are lessons to be learned.
When you asked, what are we in Colorado going to be or going to do, I also think that there is something that we can do no matter what happens with the act. There are so many issues that we need to fix, and that we have a personal commitment. We can have a personal commitment and a personal impact. So I happen to sit on Annie's board, and this wonderful organization, the Colorado Health Foundation, is helping other organizations create this movement to become the healthiest state. And I think that that's when we all, no matter what happens in Washington, what happens in the Senate, that is something that we can each do. We talked about how there is a preventive service that would happen with the act, but we can each work on how can we prevent, how can we become healthier, how can we teach our children. We happen to be looking at some statistics the other day, and in terms of Latino children, in terms of sugar intake in Latino children, up from the moment they're born to age 19, compared to the white counterpart children, they're about the same. What happens is that after age 19, the sugar intake in Americans, white Americans, goes down, way down, and in Latino and African Americans goes up. So I was asking, this doesn't make any sense. Why is it that for children, for adults who are conscious adults, why are we doing that? What are we choosing to? And then we started researching a little bit more, and we found that a lot more commercials, spots, television spots are directed to Latinos and to African Americans. That, there's a lot more poverty in these communities. There is a tremendous amount of reasons why that is happening, but it is happening. And so we need to be conscious not only of ourselves, but what can we do so that these communities understand. And it's 25% of our state, so it's 1 out of every 5 persons we're talking about. It's not, once in a while we see a Latino. There is a lot of people. So what are we going to do to get this community to be more conscious and to become healthier? What are we going to do in our own homes to get our children to be more healthy?
I want to go back to, and thank you so much for pointing that out. And I think that is absolutely part of our conversation, both looking at our state as a whole as well as disaggregating around specific populations and really tailoring our health care solutions to those populations. I want to go back a little bit to, Joan, your comment about, it was time for some federal overlay. And my sense is, as I think about my mom in her late 70s in Connecticut, who sees this kind of Affordable Care Act as that big bad federal government coming, swooping down and, taking away my choice and taking away, I guess I'd like to explore a little bit more, knowing that there have been a number of states that have taken some of their own initiatives, why we think it is important for that federal overlay. I think that's a big question on the part of a lot of people. They just don't understand why Washington has stepped in and taken this over.
Well, I'm first going to give a little disclaimer that we had discussed this over lunch. So with all due respect to your mother, hard not to remind her that the federal government pays for all of her health care.
Thank you very much.
That mean?
Must be true. there they are. They came down.
Yeah.
God has spoken. And she is just paying attention right now.
But actually, elders, I think, are one of the most important reasons why this is important, because the demographics alone are changing the numbers of people. We're living longer. Women in particular, this is where gender really comes into play. If you look at state data on the population that we call the dually eligible, these are individuals who are getting their Medicare benefits or their primary health insurance, the federal government Medicare program, but they're also either disabled or low income, and they get Medicaid as their secondary insurance, and that's a state and federally shared program, half and half. If you look at the profile of this population, frail elder women, they're 80-year-old widowed women. They may have outlived their children. They have an average of, 5 providers because they have primary care and specialists. They're on 10 to 12 medications, which they need, and no one is coordinating these services for them, except their children when they can, and when we can understand what it is we're supposed to be doing for our frail elder parents. So it makes no sense for Lynn's mom to be getting better coordinated, organized care where the providers actually have modern tools to talk to one another and don't rely on the patient to show up in the exam room trying to remember what medications she's on. They can actually punch in her number and they see her record and they know what she's gotten and they know she was in the ER over the weekend. And what a fabulous way to make sure that that patient is getting everything she needs. Versus you could live in another state and you get none of that. That's a great example of where we need more consistency. We need more consistent resources that go out to communities. We need more consistent standards for what value and quality look like. And we need some, consistent networks and service delivery models and payment models. We have to reward providers providers who do a good job in Florida should get the same payment as providers who do a good job in Arkansas. And that's where the federal overlay can be useful.
You know, we're also a transient, country.
Yeah.
I mean, people don't live in the same state their entire life, and they move. And, being able to accommodate that. The other thing is the federal government pays for an awful lot of health care. I mean, Medicare as well as matching the Medicaid in the states. And so why shouldn't there be some kind of federal oversight? It's logical when you're paying that much. And I think that, Joan is really such an expert on this. It's looking at the different populations and how it affects the elderly, how it affects the transient population. The earlier question you asked about, so what happens if it's repealed, how is it going to impact us? I'll tell you what, I've got 2 kids who are still on our insurance because their employers aren't providing insurance, who are, will not be eligible for that if it's repealed. Now, I think there's a lot of people out there that are taking advantage of that one special provision that went into effect right away, that we can get our kids that up until age 26 insured. There's going to be a lot of, I think it will be a rude awakening to people if it's taken away, not just that, but the, guaranteed issue. If it's taken away, people will go, wait a minute, I didn't know that's what the act did. I didn't know that there were going to be people uninsured now that, or can't get insurance because of pre-existing conditions. Because the rhetoric has really masked what the real benefit and what the act is really doing. So there might be a silver lining if it's repealed, and that is outrage that people will feel of something taken away from them.
The other thing that I would add around why this overlay is important is probably less obvious, and that is we shouldn't kid ourselves into thinking that every state and had the will to actually do what some of these early pioneer states did. And so it reminds me of that thing with the penguin standing on the cliff, and a couple jump in and a couple jump in. Sometimes you need the cosmic broom to come and push them all in. And that's what the feds have the ability to do with this sort of thing. And even if not a ton changes substantively, should this thing go away, as I said, we're on the road. I mean, what are we going to stop all the work we're doing? It just isn't going to happen, and in part because people do and are already appreciating at least the insurance reforms that have happened. And that's not even nearly enough in terms of what we need.
They haven't been communicated. I mean, the big fault of the administration is they've not been able to explain all the benefits. They've, had the arguments and the counter arguments out there, and a great portion of the ACA is an insurance coverage, it's coverage reform, and that's a necessary step. And I think the other altruistic reason to have the federal overlay was an ideological thought that people shouldn't go bankrupt for health reasons, that there shouldn't be those lifetime maximums, and they should get preventive care. So much of it was the insurance-related reforms, and I agree with Annie. I mean, when that gets taken away, having been very briefly in place, I have so many contemporaries who their kids are on their health plans, and it's a great thing because honestly, with the economy, they're not employed yet, and they aren't on employer-sponsored coverage, and so it's made a big deal. And I'm sure maybe Jandel even knows the numbers of them, but it's a lot of people getting coverage that have never had it before, and not having to lose your home. I mean, I just think that's a heavy price to pay if you just happen to get sick. So those were some of the ideological, I think, things that they felt were true across the country as opposed to a state-by-state approach.
You mentioned what the percentage of coverage the federal government had.
It's about half. And if you put TRICARE in, that is the military, it's even more than that. So this notion about, quote, government takeover, it's here. To the extent that anybody cynically states it that way. The other thing that I think is really cool about the fact that the government stepped in is, the creation of the Center for Medicaid, Medicare Innovation, and the Patient-Centered Outcomes Research Institute, whatever the I is for, I can't think of it right now. Those two things, there are folks in communities, there are organizations in communities who've been clamoring to try to get some things done. And one of the big rate limiting steps, in addition to sort of the collaborative nature of that kind of work, is money. And what's really been neat is to watch communities get excited about what is possible. And I actually think that's a real important role for the federal government, is to unleash that sort of innovation. and hopefully not over-regulate it till it's no fun. But it is another, I think, great benefit of this thing.
So as someone who is a relative newcomer to Colorado, having been here now 5 years, and you talk about the fact that Colorado has this really strong history of moving in this arena, what makes Colorado different than other states on this issue? Because I got to tell you, I'm learning a lot just by sitting here listening to all of you talk about, oh, we've been doing this and we've been doing this, and I don't know about other members of our audience who I see shaking their heads either knowing about it or going, oh, wow, I didn't know we did all that. What makes this state such a leader in this area?
Our general health status, we are fundamentally a healthy state in many, many ways. We're a very active culture. We have people move here because of the wanting to live in an environment that supports that activity. But we've come to a scary, screeching halt in terms of improvements in many, many areas. And so that Annie can talk to better than anyone. And it's scary to me that we were performing very well on a lot of outcomes and indicators for many, many years, and now we're catching up with all the bad states. And I think it really has motivated people to say, well, no, we do not want to be like Mississippi. And so what are we going to, poor Mississippi, so what are we going to do to stop these bad trends from happening? And how can we come together, whether it's about childhood obesity or coverage expansions or reducing healthcare costs? And I think the other thing that's somewhat unique, because we are a purple state, we have had some good successes in bipartisan efforts where it's not about political parties and it's not about who you voted for. It's about what's good for our communities and for our residents. And people have come together across the aisle in some pretty significant ways.
A question to that I think we'll just get into some of the demographics. One of the things as an educator I'm really struck by is the Colorado paradox. And so, those of us, and I'm a perfect example, who bring our, degrees from other states, and then we elevate the educational attainment that Colorado shows up as. And yet when we look at our population of men and women, boys and girls who live here in Colorado, there's a paradox between their educational attainment and that of those that we bring. So I guess my question is, when we look at healthcare, and I appreciate, Joan, your perspective on we're a state that's healthy and we have this activity, we have this wonderful sunshine and the like, what happens to populations of men and women, boys and girls who live here? I mean, it sounds like, Toti, a little bit, from your comments previously about how do we look at the differences based on race and ethnicity, and how does that show up? Or what about socioeconomic class, and what are we doing in Colorado to address some of those issues as well?
So the paradox, the education paradox matches the health paradox. So we import a lot of healthy people, but we don't score well. You can get this on our website, the Colorado Health Report Card, and our kids get a whopping C- grade. If your kids brought that home year after year after year, you probably say that's not good enough. And I don't think people in Colorado think that's good enough. And I don't want to be a total downer, but I think it's really important that we be honest about the health of our population. We love to say, oh, we're so healthy, we're so outdoorsy, look at all the people riding their bikes. That is a limited population. We have families that live in communities that do not have sidewalks, that don't have safe routes to school, that don't have lighting in their parks, that don't have lighting on their streets, that don't have the opportunity to take a walk after dinner, that don't feel safe going out of their house. How do they get that exercise? That don't have access to food and healthy food in their neighborhood. So, we can fix those things, if we all decide to face up to the facts and say this needs to be fixed and this is a priority for our state, that we want to have healthy kids, because healthy kids are going to be better educated kids, they're going to do better in school, they're going to have more productive lives and that type of thing. Then if you want to get into the disparities, it gets scarier. When you take this data and you break it down by Latino, by African American, by income, so it's a reality. Again, it's, you know, you mentioned Mississippi. Our adult obesity rate today is where Mississippi was in 1995. You know, that isn't that long ago. So if this were 1995, we'd be Mississippi. That rate is continuing to increase. There's no policies right now that's going to cause that to change. We've got to figure out how to change that and start the movement.
You know, the interesting thing about what you're saying, Annie, is that they're actually related. You know, it's not just that there's this thing called the Colorado paradox in education, and it's all the same. And one of our opportunities to do work differently is to start to work across these sectors. And to the extent that there's some language that we can frame it around, health equity and in particular the social determinants of health, one of which is economics and is education, and you start to think about it that way, and what's our opportunities to sequence and start to prioritize this work. Because, in fact, back to coverage, just because folks have cards does not mean they know how to use a healthcare system at all. So there's a lot of sort of assumptions that go into just the notion that coverage is magically going to fix the things that Annie's talking about, or even having prevention measures in a bill or somehow or other going to make this thing, I mean, in the law, are going to make this thing work. It's not that simple. So.
Oh, go ahead, Tony.
Oh, I was just going to add that, thank you, Chris, that there is just like we're talking about how many things are happening in the health field in the positive way, there is also a lot of things happening in the education field in a positive way. So there is a lot of, Colorado is known in other states from being at the forefront of change. So that is something that we should look at it as a positive. That we do have negatives, and we do need to be very conscious of what's happening today and where we continue to go if we don't make change. But I think the word education is so important. We need to we need people to understand how much each individual impact and choice really makes a difference for everybody. We can touch, and you know, a very, very quick example. My son believes that I'm a health nut, and so he keeps telling me how, but mommy, do you have to be so healthy? And I keep saying that, yes, we have to be so healthy. So he was telling me the other day that his PE teacher was telling him how many calories the McDonald's hamburgers had. So he used to ask for McDonald's, and now he's not asking for McDonald's. We've actually found a yogurt parfait that is wonderful in McDonald's, and I kept asking, you know, making the meat a banana if I had to give him a hamburger. But the influence, really, of this man that I only met once, 2 weeks later. So, mommy, Mr., and I forget his name right now, but Mr. Smith was saying that we need to eat more fruit. I said, that's good. What was he talking about? He said, well, because it gives us energy. He said that to run better, we need to do that. And I thought, you know, this is my kid in Douglas County. I wonder what the kids in, I don't know, somewhere else, if they're listening to that. It was very sad to learn, as I said on the board, one of the things we were debating is how can we help kids have PE? So apparently, PE is not all kids have PE. That is how can that happen, that the kids don't have PE? But it's not as easy as, oh, what about a school? I mean, there is a really good reason why they don't have PE in some schools, and what can we do? Because if we change that, you know, if we help education, if we help change that, then maybe we'll also at the same time have teachers that care so much, that are better teachers and that are working with their kids and in the education of not only what they do, but how farther they can go. Something else that is happening also to thanks to the Colorado Trust, the Colorado Health Foundation, and other organizations, there are so many schools right now that are having healthy lunches. And so they don't have fried things anymore. They do have the French fries once in a while, but it's much better. They're educating the chefs. So if the chefs from the schools don't even know the trash that they're giving the children, how can we blame them for giving what they're getting our kids used to eating? So that wonderful things in the industry of education are taking place that should be happening even more and more, especially in the lower populations, lower income populations.
Well, I'll just say something really quickly. We just went to Healthy Foods at one of our hospitals. We took out all sugar drinks from Lutheran, and the protestations were quite mighty by the staff. And you'll find in the fridge, along with the nutritional ensure that we give to patients, some Cokes and Mountain Dews are hidden in there. But I mean, I do think that is a big thing. That is a controllable thing. It's a trend. It is a cultural difference. And it's not something our culture is really used to, having someone instill upon them, but it does help. And the other point I was going to make, just relative to the obesity epidemic, it's these chronic conditions that I think if we can address the care models for, we'll be better off. I think, historically people have thought, geez, I want to have my steak, I want to have my bourbon, I want to have my cigarettes, and when I need a bypass, I'll go get a bypass, and I have insurance, and all of that compounded, but literally that has been the culture in America. And I think now the challenge is, how can we work together across all of the community and really with individuals to say we have to take some personal responsibility? And for those with chronic conditions now, how can we keep them out of a hospital setting? How can we help monitor whether they're compliant with their meds, if they have high blood pressure, if they have congestive heart failure, which is something my mother had, and I can tell you the repeat hospitalizations were just vexing, and it was always the same thing. She didn't take her Lasix, her fluids built up, her breathing got bad, and we'd go to the same emergency room, and I would have to have my whole list of meds that she took, and I'd have to repeat it every single time. So, I mean, there's so much inefficiency and sort of management of people's health that I think we really have a great possibility to impact if we could get together and sort of get that model thinking, as opposed to just when you're sick, come, you'll get taken care of, and then sort of put back out there on your own with no treatment plan or follow-up.
And yet, I think the thing that we have to call out as folks, I mean, I've spent my whole adult life, at least, in healthcare and in medicine, is that we created this system. I mean, to sit here and say we have either through the miracles and the magic of the media, or the smoke and mirrors that I'm a physician and I'll say it, that we spin in the rooms, not based on any evidence, we have actually sold America to think that you can do all the stuff you do and don't worry, we'll fix you. And so that digging out of this craziness that we've created, because no one would create a system like this. I mean, I don't even know how you'd begin to create this monster that we have, and unraveling it is going to take a ton of time, and beyond time, it's going to take will. Mm-hmm. And I think these pushes, like the Affordable Care Act, you could even argue some of the insurance reforms, although I work for a health plan, and I think these high deductible plans are frankly, I like to think that there's some sort of a transition on the way to something better, because they not only make it that they do actually decrease unnecessary care, but they unfortunately also decrease necessary care when folks can't. I mean, these deductibles that are out there today are just outrageous. We don't do that, thank heavens. Arms aren't that big, but aren't that large. But we've behaved ourselves into this situation, many aspects of the system, and frankly, we know this. Mm-hmm. There's a lot of folks who got rich off this system and continue to, and they are some of the quietest and the most resistant folks to change, or sectors to change. So it's not as simple as saying all we communities come together and it's magically going to happen. It actually starts with us in the system. Mm-hmm.
Well, it's an interesting, for those of you who are studying economics, you could get a room like this where this half of the room thinks the fact that the healthcare sector is 17, 18% of our GDP is a good thing, and the other half thinks it's a bad thing. And the fact that it is a huge economic driver it creates jobs. It's Wall Street. In a community, it might be the largest employer. So we can go into a community and we could say, you know, you guys could be so much more efficient if you close that little rural hospital, which has some questionable outcomes anyway, and send everybody to, 20 miles away to the bigger place. Or everybody in the community would be better off if you did mail order pharmaceuticals. They'd all save a bunch of money, but then what happens to the little local pharmacy that's been there for 40 years? I mean, almost every time you find an efficiency, what somebody like me would call an efficiency, someone else is going to lose. And that's why having a conversation like that at a community level is so important. Because a community, however you define it, whether it's a county or a city, I think even a state gets a little big, you can figure out how to design those things so that there aren't as many winners and losers than when you just come in and try and impose things. And then the solutions reflect the values of that community. They reflect the values of the consumers and the diversity in that community. And I just think that I believe in pilot programs, and I believe in trying to figure out how to ramp up the programs. But I think we oversell ramping up and taking demonstrations and saying, "Oh wow, it worked in Grand Junction, so we can just make this work everywhere in Colorado." That's not going to happen in many cases, because what they did in Grand Junction and Mesa County really reflected the culture of that community. And it might work in other communities, might not. They might have to tweak it and do something a little different. But you just have to avoid as much as you can winners and losers, because these are jobs and economic drivers in a lot of communities.
I don't want to pick on Grand Junction. I mean, we put Grand Junction on this pedestal, and, that's a scary place to be. But I was looking at their health outcome data the other day. We know that they have a good healthcare system. We know that they have a lower cost per capita healthcare, but still are delivering high on quality initiatives. But their health outcomes are not as good as the rest of the Western Slope. And it goes back to what Jandel was saying, that healthcare is really only 10% of your health. The other 90% are other factors: your lifestyle, your income, your education, your environment. And so we could create the perfect healthcare system, and we still aren't going to be a healthy population. It's not going to. And the other mystifying thing to me is that if 90% of our health is based on factors, lifestyle, et cetera, we only spend 5% of the healthcare dollar on prevention. Yet we know that that's the most effective return we can get. But it comes back to the unwillingness to spend money up front for savings down the road. I mean, our kids don't know how to do that. We don't know how to do that.
The other part of it is, and I'm so glad you referenced the Health Affairs article that talked about the 10%. That the 10% is of the entire attributes to your health is what we do in healthcare. And that's where we're spending the $2.4 trillion. Right. I mean, and so what are we doing? You know what we're doing? We're pulling bodies out. And we have the opportunity, if we can get this sexy some kind of way, or at least maybe there's some money to be made in it, to shift more into the built environment, what our food really needs to look like, and what we should be eating, what neighborhoods need to be like, because we know place matters and plays a big role in this stuff. If I look at 2.4 trillion and say if we could just shift a bit of that into this, what is possible? What is possible?
The closing question I want to ask before we move to questions from the general audience, you've started to answer. And that closing question is, what systemic changes and/or cross-sector work do you believe is required in order to truly connect the big dots in health and healthcare? Who needs to be at the table? Whose voices are we not paying enough attention to? And what are the structural, economic, and social changes needed in order to bring about these changes? And you've started to talk about that. But if we could just get a little more into that, and then I want to open it up because I know there are some people who are eager to ask questions.
that question, your question about who's not at the table enough, I would say more consumers. I mean, we're all consumers, whether you're the president or a health policy expert or a physician, you're a consumer. But I don't know that we completely understand well enough, what do each of us need as individual consumers to really motivate us and educate us and help us do the right thing. And I think to try and have a thoughtful conversation about what personal responsibility means, I know what my definition is of it, but how do we have that in a public policy setting without it turning into being a punitive thing? Because that's what tends to happen. We say we want people to take personal responsibility, and the only way we've just defined that so far is just paying more out of pocket. It's, what are the tools and the information that I need for me to make good choices for myself that might be very different than every other person in this room. And there's some interesting research going along in that area about how when physicians use certain education aids in a room with people, if you say you can have this expensive surgery, Jandel should speak to this, you can have this surgery, or we can try some physical therapy, some other treatments, and the physician or the provider really sits down with those teaching aids and says, here are the pros and cons of this one, here are the pros and cons of this one. It's amazing how many patients choose the less invasive, cheaper procedure. But we have to design a setup and an environment, and then we have to pay those providers for all that education time, instead of just paying them to do the surgery, to create a culture where we can take better personal responsibility. So I think consumers are, not that we aren't all consumers, but they're not at the table enough to really help us understand what more people need.
To add to that as well, that minorities are not at the table. Consumers in general, but minorities even less. And the Act actually recognizes that, because this is dedicating quite a bit of amount of money to train physicians, multicultural physicians, and other type of health, people in the health industry. But one thing that to me, you mentioned, is how different is health, even just going to a doctor visit in Colombia, where I come from, or in the US. And you mentioned, allowing the doctor to have that little bit of extra time to explain to the person is so important. Here, everything is so fast. You go in, it's out. By the time I even take my question, it's like, oh my God, I forgot to tell her half the stuff. And then that half of the time, my list that I forgot to tell her, probably could have been something that I could have prevented in the future. And I'm a healthy person. So I wonder, the culture, because change is the most difficult thing that can happen. So how can we get that change within the health industry so that, I want to say people, I don't want to insult saying that people don't care. I think it's just a matter of, it's not that they don't care. I mean, they went into this industry because they probably are the people that care the most. But the system doesn't let them. They don't allow them to be better at what they are really good at.
Right, and for those of us who have some sort of educational privilege or socioeconomic class privilege, we can slow that healthcare provider down, or that person we're having the conversation with down, and say, wait a minute, I have a series of questions. What happens when you don't have that sense of self and that sense of, I can actually slow this expert down? Because we've also created a community, right, of experts, and we're afraid to question them, depending on who we are. So.
The group, I just wanted to tag on, and I actually found something this morning that I've been looking for, at least thinking about driving around. And it's like finally asked the question. When we talk about health equity, which is, who I think is missing from the conversation are vulnerable communities or populations. And the list is longer than the obvious ones that we think that come to mind around race and ethnicity, but gender, and disabilities, you name it. But the way that we talk about it, we say that we need to think about health equity from the perspective of its moral imperative and its ethical imperative. But there's a big economic imperative too. So I asked the question, if we could eliminate the health disparities, that is, truly get to health equity, how much money would we save? So I finally put the question in and asked, and the Joint Center for Political and Economic Studies, which actually is a group that does, a center that does studies in minority communities. They focus just on African Americans and Latinos, as I could tell. And they did this amazing study where they estimated the economic burden of health disparities in the United States, and they used 3 measures. They looked at direct health care inequalities. They looked at the direct medical costs, I should say, of health inequalities. The indirect cost of health inequalities, which is really all about productivity, the things that Donna Marshall knows so well, and the cost of premature death. And what they found between 2003 and 2006 in this country, the combined cost of those inequalities that I talked about in premature death was $1.24 trillion. I mean, there is money sitting there if we just focus. So in terms of the cross-sectoral work, we have to take into account some very deeply seated classism and racism, some of these things that affect who actually even gets a seat at the table and where we focus. And we've marginalized a lot of this kind of work that if we would pull it in, oh my gosh, there wouldn't be winners and losers. There'd only be winners. I mean, because those are dollars that are redeployed to do other things. Eliminating the disparities for minorities would have reduced direct medical care expenditures by $229.4 billion for those years. So this is the kind of information that we need to socialize as leaders in this field and get focus on this notion of health disparities and get it out of the realm of saying, oh, that's that black thing, or that's that women thing. This is an economic reality. My health's good because I got money. Right? And I'm smart, and all the things that most of you in this room have. We are of privilege. But so it isn't about us at the table, but yet we're the ones who are at the table. We've got to have these voices or speak for them.
But, you know, Jandel, I think that's an incredible fact. You know, we often use that term that health shouldn't depend on your zip code, and yet it really does depend on your zip code in a lot of ways. But how do we translate that to people so they say, well, what does that mean to me? I mean, you know, why should I care about your health? You know, why is it in the common good for us to care about each other's health? You know, we kind of get there with education, right? K through 12 education, we all say whether we have kids or not, we should put money into the pot because it's good for society, it's good for the country. We haven't gotten there with health. We haven't established health as a common good, and yet this isn't about altruism. This isn't about you know, just wanting everybody to be healthy because that's a good thing to be. It's about the fact that we're bankrupting the country, our state, the next generation based on the fact that we don't care about other people's health and we're not doing anything about it. So when you talk about systemic change, I think that fundamental value of health as a common good is a really important thing to get across. And then the cross-sectoral thing, I think health and education, you know, if I could decide, I'd put all our money into health, into kids, because that's where you get the biggest return for your dollar. And you do it through schools, and you make sure that schools understand that they're going to do better if their kids are healthier, and you need to come together on a common agenda.
Well, I would like to thank you so much, everyone. Could we round of applause for our panelists? We have this opportunity now for questions. We have 2 of our fabulous student workers here at the college who have microphones. I think actually, Krista, we're going to make you come up front and get this one. But if you could, please raise your hand, and one of our fabulous students will bring a microphone. Krista, we've had a gentleman here, and then there's a woman back here, Liz, who'd want to. Thank you. No, I think you get to start.
It's been a wonderful evening, and I have a question for any of your panel. I am a primary care doc. I've been in practice 36 years, imported from another state. And there seems to be a vanishing group of primary care physicians, and more of the pipeline of young doctors going into primary care is shrinking, and specialties remain well paid, and so they can pay off their medical school debts. So what does the panel think could happen to help make primary care more appealing, more financially available so they can still pay off their debts, and then help fund or help staff the medical homes that will be part of healthcare reform? Or are we headed more towards not having physician primary cares, but perhaps tapping into the large pool of advanced practice nurses who do a very good job?
Well, I'll take a shot at starting as the one specialist primary care type doc. I'm an OBGYN, so we sort of straddle the fence between primary care and specialty care. And what I'd say is that the model is changing. The medical model does need to change. If I'm really honest with myself, in 25 years of practice, I didn't see all sides of my patients. I couldn't. The nurses bring a particular view. Health educators bring a particular view. Community folks bring a particular view. And to think that I, as a physician, could do it all is crazy. I think some of the issues with primary care physicians, I think that was at a Lancet or a New England Journal study a few years ago where medical students were asked what they plan to specialize in. I think for pediatrics, it was 7% plan to go into pediatrics. Internists, it was 4%, and family med was probably around 5 or 6%. And it's because the career is no longer sustainable. There's so much that's put on the individual physician to do that it's crazy. You can't do it all. So that one of the other really cool things that I think we're getting our heads wrapped around is that, sort of whether it's the notions of physician autonomy and that we're at the top of the heap or whatever, that I have a special skill I bring. I hope I do it well, and I need to have a team to help me manage patients. And frankly, part of that team needs to not be in my office. It needs to be in the communities. I think that's part of it. I think the bigger issue, and you touched on it, is medical education is hideously expensive, and what are we going to do with that? I know the other thing I would say is I think we actually need to flip the paradigm, the payment paradigm, completely around. And primary care, whether they're advanced practice nurses or others, those salaries have to come up, and we've got to get some leveling out. And so some of the payment reform ideas that are being bounced about have an opportunity of doing some of that. But the careers are, there was another study, if I'm not mistaken, that said that if we did all the stuff that is now expected of us because of now ACA, or let alone certainly guidelines, evidence-based guidelines that have come about, I think it actually extends your day by 6 hours or something to take care of an average number of patients you see in a day. We can't do that, and it's silly to think we can. We didn't do it very well. I mean, I had the pleasure in privilege in Kaiser Permanente as a staff OBGYN of working alongside nurse practitioners who I shared OB care with. And there's no doubt that my nurse practitioner colleagues did a better job taking the time to make sure the education components were taken care of. And I was good at it, but I know that they're better at it, and it's just getting honest about what's the skills I bring and what do patients need. Because this is a problem. And I frankly, given where the models are going, do not think, I'd ask Joan or others, I don't think the answer is educating a ton more physicians. And that's a doc saying that. I have to turn in my CMS card after this.
Right.
I will say to your question, I agree. I think we do need a solid pipeline of physicians, but we need to use their time and expertise in better ways. So the core of that practice might still be a physician, but I would argue, would our shortage of primary care physicians in 2020 be as great if we used other people in better, smarter ways? So when I said, you want that person sitting there in a room educating somebody or doing nutrition counseling, no, not the physician. Let's use the physician where the patients who are coming in who absolutely need to see that physician and need that level of expertise, but we need health educators. We need to surround that physician with people who can help them help their patients get healthy and stay healthy, so we're using them in the best way possible.
I would just add a couple of things. I think the employment model is now an interesting aspect of all of this, and the pendulum does tend to swing if you've been in healthcare long enough where, employment's desirable, then it's not desirable. But the cost of running a practice for a primary care doc is just out of this world. And then when you put on top of that the push for electronic medical records, and they should get this system in their practice, and when are they going to have time to learn how to, run software and run a system, I think that is something that is appealing to some, to have the employed model. And I think just personally, I'd like again to see the incentives change so that treatment doesn't have to be an office visit and you get paid as a primary doc. And I'm sure we as patients and consumers want that too. I mean, every other service has become electronic. We can do things via email. Why can't we get our lab results? Why can't we make appointments? And we're moving that way, but I think the incentives aren't quite there yet from a payment perspective, and that again makes it difficult to sort of make the primary care doc satisfied in what they can do in the amount of time and still make enough to make a reasonable living, and then the patient to get the attention they need so they don't feel like it's a drive-by and they've seen everybody but the doc comes in, just briefly.
Yeah, I like to say, if you think I want to use Lynn's words about privileged, if you think I or we love convenience in how we get our health care, don't you think that low income and complicated and sick people and vulnerable people need that and want that even more? They want the same level of efficiency and use of modern tools. In fact, I would argue it's even when you're working 3 part-time jobs and getting paid by the hour and you cannot afford to take time off work, all the more reason you need to be able to email your providers and use mail order pharmacy and all the other convenient things that we take for granted, those of us who have privilege and have insurance. So this notion that somehow just because people come from another culture or they're not as well educated or their income is lower means they can't use or won't use modern communication tools is just absurd, and we have to stop saying that.
I wish my mom had access to the kind of access I have at Kaiser, quite frankly, where I can find all of that information online. It really is extraordinary. And she is very computer literate, so there's no reason for someone who's almost 80 to not get on the internet and be able to do some of this. We had another question.
Actually, my question was related to access. We're talking about expanded coverage, which is wonderful. We all know it makes sense, and yet we have a crisis in our provider market. And I don't think people really understand that. It's great to provide affordable product to an expanded population, but if you have I work with physicians across the country, and they are exiting in droves. It's become so difficult, so complex. The reason your physician can't sit and talk with you is because they have no time to even be in that room. There are so many demands on their time. So I think I don't really know whether the population realizes that that is truly a crisis. We're going to expand, but these people will not have a place to go to be seen, in my perspective. So that was just kind of.
Well, this is another one of those sort of hidden things that's in the Affordable Care Act. A lot of support and financing for training programs, both for primary care providers, for nurses, for dental hygienists, reimbursement programs for student loans. But again, this is one of those areas where you can't just, you have a continuum of interventions that need to happen, and you can't just pick one or two and think it's going to get fixed. You have to address all of them. You have to address pipeline programs. It sort of goes back to the kids. You have to make, we have to have healthy kids ready to learn, learning well, learning math and science by the time they're in 7th and 8th grade if we think we're going to have a decent pipeline to go to medical school or nursing school or whatever. Then we have to pay providers to do the things. If we say we want them to focus on prevention and early intervention and educate us instead of constantly, treating us or doing invasive things, then we have to pay them to do that. And the payment models, there again, lots of wonderful experimentation going on right now. And we just have to figure out what the right way is to do that. And then we have to be willing to look at some different service delivery models. I am a firm believer in everybody being able to practice at the top of their license, and if they went to school and got trained to do something, by God, our rules and regulations and payments should allow them to do those things. We shouldn't be preventing dental hygienists from doing the things they are perfectly trained and willing and able to do just because it threatens the dentist in the local community. I'm sorry, we're never going to fix this if we keep pitting our providers against one another like that. So those are the hard, tough conversations we have to have. I mean, I started my career in women's health, and back in the 80s, we were having these arguments about nurse midwives and putting the OBGYNs out of business. And we are way past that now because we put some right regulation and payment. We put some equity in there so that you don't hear that kind of tension between, I'm sure it crops up from time to time, but not nearly the way it was in the 80s. So we need to address our other provider groups and try and bring that same kind of stability to those models as we did, I think, between OBs and midwives.
There's a question in the back. Yeah.
Yeah. Okay. I hope you can help me. I think I can.
Okay.
You can help me with one of the issues that I'm having in my class when I teach health economics or healthcare policy. I noticed two major topics. One is social determinants of health, properly named. The other one is Affordable Care Act. Most of the issues that we are discussing today has a lot to do with not healthcare system, but our employment policy, our regulation, deregulation, our social and economic policy, how we do the zoning, how we do transportation, how we do, regulate food and drug, so on and so forth. And I really want to thank you for highlighting that aspect. Because healthcare system can only solve the last minute aspect of the whole problem. As the social determinants of health people are saying, economic policy is the health policy. You have to solve the problems with class, social classes, race, gender. These are the three major sources of all those social determinants, and it begins from there. That's number one. I talk about this in the class. But we also talk about the Affordable Care Act and the healthcare system, how it works. I noticed a couple of things that are like putting more emphasis on individual responsibility, making comparisons, balances between consumers and providers. I believe if you believe in social determinants of health, those individualized aspects of the problems are going to make sense within their social context. And putting a lot of emphasis on individual responsibility, in plain English, drives me crazy. Nowhere else in the world we use those words as much as we use in the US. Magic words, individual responsibility. Another magic word that we keep talking about, I think the specific example came from comparison between Grand Junction and the rest of Colorado, whether we can implement one model or not. I'm not specifically talking about that model, but whenever we think about something completely different or by our standards, by US standards, radical, no, it's not, we cannot do this. We are going to do these things in a gradual fashion. I'm going to try to keep it short. But what I'm trying to say is, our healthcare reform throughout the history, from 1911 until now, it is always an incremental effort. It is always a patchwork. But when I introduce other healthcare systems to my students, show documentaries, look at the way how they organize and how they pay. There are two aspects of it, any healthcare system, if we want to simplify. One, how we organize and deliver healthcare. Two, how we pay for it. When it comes to organizing and delivering the care, all other systems are paying a close attention to integration and coordination. That's why they have more primary care physicians than specialists. We are the only country have more specialists than primary care physicians. And now it's a crisis. And another thing that they do, if the system is getting more expensive, one way or another, don't get me wrong, there is no one silver bullet. Canada, UK, Germany, Japan, Sweden, Thailand. Look at them, one by one. Each try different things, but one common aspect. They control prices.
So would you like
our panelists to
what
respond?
I'm sorry.
You promised me you were going to keep it short.
I'm terribly sorry. I was going to start by saying that I'm going to play the devil's advocate as one of the few males making an appropriate role. But what I'm trying to say, all those issues, social determinants, how the system is going to work, if we are going to talk about that, we have to put them in a perspective. And could you tell me why is it so difficult? Why is it so difficult to entertain alternative ideas? Because to me, Affordable Care Act is Nixon plus Romney presented
Because
as a
too many
demo.
people are making money in today's environment. If you can't, we have very powerful lobbies in Washington. We have lots of influences. You can't change something when the pharmaceutical companies, the healthcare providers, medical technology, the equipment manufacturers. I mean, that we're a capitalist society, and when people are making a lot of money and you're trying to save money, that's coming out of somebody's profit. You don't save money without it coming out of somebody else's. It was exactly what you were saying, Joan.
The Medicare program,
yeah. I mean, there's too much money being made.
A couple years ago, Medicare decided to competitively bid. This is exactly what you're talking about. Government controlling the price. They're spending a lot of money on durable medical equipment. They did competitive bids. They hired vendors. And now we're hearing two different stories. The federal government saying this has worked beautifully. It saved us hundreds of millions of dollars. And guess who's telling horror stories? The DME, the durable medical equipment providers. Now, I'm not saying it's worked perfectly. I have no idea. It's not my area of expertise. But it's exactly what happens when you try and intervene in an economic way, like what you're suggesting. And I would validate we're pretty snobby. I mean, we know there are other things we could be learning from other countries, and we're not very open-minded about that as a culture. Yeah.
That was my question. They are capitalists too, so they are not.
Comment, throughout this sort of, we'll say the round last of healthcare reform, well, why don't we do it like Germany? Why don't we do it like England? Atul Gawande wrote a really great article that actually talked about and chronicled how those systems come up. And the reality is all those systems came up out of an historical context. And we have a different historical context. We have so that we're not going to be able just to plop those down. It's way, way too simplistic to think that that's how it's going to work. The other example I was going to give with Medicare is Medicare actually said we're not going to pay, and I don't even know what the state of the art is anymore, but they weren't going to pay for the CT colonography or colonoscopies. They weren't. The evidence was not there to actually. So they said we are not going to pay for it. They had such a whatever, you name it, rain down on them that they're covering it. So the other thing that's happening here we have to be very real about is that politics trumps policy, good policy, any day of the week. And so therefore, one of the other voices we have to have is we've got to have voices. We've got to have, whether it's consumers or the vulnerable folks, we got to buy ourselves some politicians, as it's been said.
Article last week where physician groups came together and said, you want to save some money, here's a list of, I don't know what it was, 45 things they said are silly to be doing. Let's listen to those providers and do something about that.
We have one more question. I'm going to take one more over here, and then... Okay.
Yes, just in terms of going back to the economics of it, and I'd like for you all to please address very concrete specifics as to what we can do as consumers to address that, because as you say, the money, the power is in the money. And we are spending our hard-earned money, so we have to vote with our dollars, if, as the saying goes. So if you could, one, address that, and two, not only, again, the people that are sitting here at the table are the people that are already kind of informed in a lot of ways. How can we get this message and this information to Mr. and Mrs. Jones that live in Park Hill, or Montbello, or whatever? How do we do that?
First of all, I think we make it very difficult in our health system to help consumers understand how they can be better consumers. I mean, I think that is one of the key failings that every constituency within healthcare. I mean, quality and price transparency, we're so, we want to get there, and what other good or service do you not know really what it costs and what value you're getting? So I applaud the desire to become a better consumer, but I do think that's one of the big mea culpas we have to admit, is we just make it really, really hard. You don't know what something costs. It's difficult. We talk a lot about personal responsibility, and I think that's probably part of it, in terms of knowing what you can do to be your own advocate. And I think we have to do a better job of educating each other as mothers, sisters, brothers, wives, people with elderly parents, and helping them become advocates to navigate this complex system, because that's another great need. But I would say we don't make it easy for consumers. I mean, that would be my reaction.
To get very tangible, I think that there's a lot of lessons we can learn from how we manage the rest of our lives. We don't purchase stuff without looking at a price tag first and making those comparisons. And in fact, you can get more information about car shopping than you can about healthcare. But I'll tell you some things that rattle our cages, we docs. First is when I say, I'm thinking we ought to do X. Ask the doctor, what are the alternatives to X? Ask physicians, what does it, and not just physicians, ask the systems, what is this going to cost? Ask them about what are the benefits of doing X, Y, Z, or the risks. What happens if I do nothing, especially in the cases of pain? Because we mismanage pain and get so many people addicted, and it's just horrible. To ask and it'll shake us out of our reverie. The other thing that you can do if you want to really read the book, How Doctors Think. I read it just to figure out how I think. So it is a fascinating book, and it gives you some real glimpses into what happens in those rooms. There's a power imbalance, and we've managed to sort of shroud ourselves in, pardon the pun, but I'm the great white hope. And I come in with my coat, and we've got to limit the power imbalance. The other thing is, I actually don't think that most people should go to exams without somebody there with them. Because you cannot, especially in the moment when I'm giving you bad news. And I always said to my patients, you won't remember most of what I said. Here's where you call me tomorrow after you've had a chance to think about things, and we'll talk again. Whether it's horrible news or guess what, you need surgery or whatever. You're not going to remember most of this. That's why you have to bring somebody else with you. I think this notion of self-advocacy or sort of advocating for yourself is something I can do. So something I suspect most of you can do. But most folks don't feel that they have we have not enabled or allowed the power imbalance in that room to give voice to it and to bring ourselves down to our patients' levels. And you can't do that when you're sitting there you sitting there with no clothes on and I'm dressed like this. What's that say? Exactly.
In a compromised position.
In a compromised position.
I might add.
Some of the very tangibles. And I'll tell you, you ask the physician, how much does something cost? I don't feel bad about this. We don't know. We do not know. I mean, that is how opaque this, you think it's opaque to you, it's not exactly transparent to us on the inside either. But sometimes just asking the questions, not necessarily because you need an answer, but it shakes us out of that reverie or that sort of the typical dynamic that plays out. And what happens is, oh, I got a player here. Okay, let's do something a little different, are some of the things I would suggest that I think we all have to do.
Well, as a dean of a women's college, I'm always eager to see a woman leaping out of her seat ready to ask a question. So our last question.
I'm actually not going to ask a question. I'm going to respond to what Jandel just said. I recently lost my mother, a 3-day hospitalization with pneumonia that was not apparent at all until the day before she was hospitalized, and she was living with me. And I am an educated, observant advocate. I spent those 3 days fighting off interventions, and I was good at it. And I had a primary care physician who had been her primary care physician advocating with me, and we lost battle after battle with those people doing things to her that made no difference in the outcome. And that was always my question. What difference will this make to what we know is happening here? When we finally got palliative care into the mix, she finally was given the care and the comfort that she needed. And I, as knowledgeable and as pushy a person as I can be, I could not control what was happening, and all of the health care dollars that were being spent unnecessarily on a dying woman. It was horrendous, in my opinion. They hurt her when they didn't need to hurt her. They did things multiple times that they didn't need to do. And so, my sisters said to me, if you wouldn't have been here, what would have happened? And I went through the list of things that I said absolutely no to. And so what this panel has said about needing advocacy and health literacy and maybe patient liaisons to help the patient who is talk about a vulnerable population. If you are a patient, you are vulnerable, period. And you need an advocate, and you need somebody, I wasn't terribly objective, but I was more objective than the average family member, because I had talked to my mother before she declined. I knew what she wanted, and I was working very hard for her to get what she wanted. So I think, in terms of education, in terms of individual responsibility, what we need is some kind of system that helps the vulnerable patient know what's really going on and helps them translate this very complex and very overwhelming system to them.
For taking time out of your busy schedules to be part of the conversation tonight. Really appreciate it. I just want to also put a plug in, and I want to thank you very much. You are very persistent, and I'm glad that you had to say what you did. Next month, on May 9th, we have the great pleasure of having Jennifer Siebel-Newsome, who will be in conversation with me as our next leadership salon. Jennifer Siebel-Newsome, for those of you who have not heard of the documentary Misrepresentation, has created a really powerful documentary around images of women in the media and how those images are in direct opposition, quite frankly, to women who hold positions of influence and power, and what we need to do to take action to change those images so that we can, in fact, have more women in leadership roles. That will be over here at the Cable Center on May 9th, and so for those of you who have come this evening, you will receive information on that from us as well. We're really excited to have her here. She's an incredible spokesperson for creating the change that we want to see in the world. So thank you again for being here. There's information about the college on your chairs as well. We are supporting these efforts for the salons through lots of support from our donors and friends. So thank you so much for considering support of the Women's College. And I wish everyone a good evening, and to go forth and think about how we can, in fact, create change for ourselves and others in terms of creating a healthier community and, quite frankly, a healthier country, because we all have a vested interest in making sure that we are healthy and educated as U.S. citizens. So thank you for your time, and thank you for being here.